Welcome to Raaonline. Today's topic is Endocrinology of Endometriosis. The true overall prevalence of endometriosis is unknown because surgery is the only reliable method of diagnosis and we have to put in a laparoscope to diagnose, and most of the patients are not ready for this invasive method. The prevalence of asymptomatic endometriosis is difficult to diagnose. In the women seeking elective sterilization, the endometriosis prevalence is 1 to 7%. In the women of reproductive age group with pelvic pain coming to the OPD with chronic pelvic pain, the incidence is 12 to 32%. In infertile women, the women coming to our OPD with the chief complaints of inability to conceive, the incidence is 9 to 50%. And if there is a teenagers with chronic pelvic pain or dysmenorrhea, the diagnosis of endometriosis is made in up to 50% of cases. And the overall prevalence of endometriosis in reproductive women is estimated to be around 3 to 10%. The prevalence of endometriosis is inversely related to BMI. So it is more common in a lean individual. Endometriosis is rare, but in premenarchal girls, but may be identified in half or more of the adolescents and young women under 20 who come with the complaints of chronic pelvic pain or dyspareunia, that is, painful intercourse. Most cases of young women are associated with Mullerian anomalies, cervical agenesis and vaginal obstruction. Now, fewer than 5% of women who require surgery for endometriosis are postmenopausal. Most have history of estrogen therapy. So, endometriosis in postmenopausal is mostly associated with menopausal hormone therapy. Risk factors for endometriosis include early menarche, polymenorrhea, black race, low BMI, low parity, number of years since the last childbirth, alcohol intake, caffeine intake, exposure to polychlorinated biphenyl or dioxin, prenatal exposure to diethylstilbestrol. Protective factors for endometriosis include high parity, prolonged periods of lactation, regular exercise, smoking. The correlation between the risk of disease and volume and duration of menses is less consistent and has no evidence based. Coming to the various theories of endometriosis, so what we see, the oldest one is the Sampson's theory or the retrograde menstruation and implantation theory. This theory holds that endometrial tissue shed during menstruation is transported via the fallopian tubes into the peritoneal cavity where it implants on the surface of pelvic organs. The coelomic metaplasia theory states that spontaneous metaplastic changes happen in mesothelium cells derived from coelomic epithelium located on the peritoneum and the pleura. Now, endometriosis in the following conditions can be explained by the coelomic metaplasia theory, like endometriosis in premenarchal girl, this which cannot be explained by Sampson's theory. The coelomic metaplasia theory can also explain endometriosis in women who have never menstruated. Coelomic metaplasia theory, which can be a spontaneous or an induced metaplasia, can also explain the presence of endometriosis in adolescent girls who have very few menstrual cycles and who have just started menstruating. Now, because endometrial cells have no access to thorax in the absence of anatomical defect, the implantation theory of Sampson of retrograde menstruation cannot explain the cases of pleural and pulmonary endometriosis. And most of these cases happen on the right side, and these can be explained by the coelomic metaplasia theory. Now, pleural endometriosis is explained by the coelomic metaplasia theory. Metaplasia in the pleura, which is derived from the coelomic epithelium, just like the peritoneum and the Mullerian ducts. Now, metaplasia in the pleura can be induced by steroid hormones or chemical stimuli released by degenerating endometrial cells into the peritoneal fluid, which communicates with the thoracic cavity via the right hemidiaphragm, and it is a more plausible explanation. Coming to peripheral site endometriosis, like endometriosis on the hands and feet. Now, metaplasia in misintegrated coelomic epithelium, it is adjacent to the mesenchymal limb buds during early embryogenesis, can explain endometriosis in unusual peripheral sites like endometriosis of extremities of thumb, thigh and knee. Rare cases of endometriosis have been observed in men which are treated with very high doses of estrogens, and this can also be explained by the coelomic metaplasia theory. Coming to the coelomic metaplasia induction theory, it is a variation of the spontaneous coelomic metaplasia theory. and it envisions that coelomic metaplasia is induced by exposure to menstrual effluent or other stimuli. Now, endometriosis in premenarchal girls can be explained by spontaneous or induced coelomic metaplasia theory. Sites of occurrence of endometriosis include the ovary, which is the commonest site of occurrence. Second is the cul-de-sac, because it is the most dependent part in the standing position, the uterosacral ligaments, the broad ligament, fallopian tube, round ligament, vagina can be a site of endometriosis, rectosigmoid and bowel and appendix can be a site of endometriosis, urinary bladder and ureter can also be a site for endometriosis. Now, what we see in this picture is like a red dots on the uterosacral ligaments, and these are the typical lesions of endometriosis. Endometriosis is 6 to 7 times more common in first degree relatives of affected women than in general population. Endometriosis is inherited as a complex genetic trait for which the phenotype reflects interactions between the allelic variants of susceptibility genes and environmental factors.